Welcome everyone. Today we'll be exploring reversible cerebral vasoconstriction syndrome, a clinical and pathophysiological perspective. Let's begin. Reversible cerebral vasoconstriction syndrome is a condition that can be both dramatic in its presentation and elusive to diagnose. To get to grips with this challenging entity, we need a clear and systematic framework, which is precisely what we'll build over the course of this presentation. First, we must establish a solid foundation with the definition and formal diagnostic criteria. These are not merely academic points, they are essential tools that allow us to differentiate RCVS from its dangerous mimics, such as primary angiitis of the central nervous system. In practice, adhering to these criteria prevents misdiagnosis and guides appropriate care. Next, we'll explore the risk factors and etiological insights. You'll find that RCVS is often triggered by something specific, most commonly in the postpartum period or after exposure to vasoactive substances. This could be anything from nasal decongestants to selective serotonin reuptake inhibitors, making a thorough patient history absolutely paramount. The underlying pathophysiology is where it gets particularly interesting. At its core, RCVS involves a temporary, widespread dysregulation of the tone of cerebral arteries. We'll discuss the leading theories, which point towards a combination of endothelial dysfunction and a hyperactive sympathetic nervous system causing the vessels to constrict erratically. Of course, this pathophysiology translates directly into the clinical presentation. The signature symptom is the thunderclap headache, a severe, sudden-onset headache that demands immediate attention. We'll detail a systematic diagnostic approach, using imaging like CT angiography to identify the characteristic multifocal, string of beads appearance of the arteries. Finally, we'll outline evidence-based treatment and monitoring strategies. Management primarily involves withdrawing any offending agents and often using calcium channel blockers to alleviate the vasoconstriction. Crucially, we'll discuss the importance of follow-up imaging to confirm that the arterial narrowing has resolved, fulfilling the reversible part of the diagnosis. Putting all these pieces together gives us a comprehensive clinical roadmap. But this detailed picture raises a more urgent question. Given its potential for severe complications like ischemic or hemorrhagic stroke, why is this reversible syndrome one that every clinician must learn to recognize without delay? So, we've outlined our objectives for this presentation. But the first question we should really ask is, why dedicate this time to reversible cerebral vasoconstriction syndrome? Why does this particular condition matter so much in modern clinical practice? At first glance, an estimated annual incidence of around 2.8 per million people might sound quite low. You might think this is a niche, rarely encountered disorder. However, that figure is almost certainly a significant underestimate. In practice, we know RCVS is frequently misdiagnosed, often masquerading as a primary headache disorder or even a psychiatric complaint. The true number of people affected in our communities is likely far greater. The real urgency, however, comes from its clinical signature. RCVS is a key cause of the thunderclap headache, that sudden, explosive headache which patients describe as the worst of their life, peaking in under a minute. Our immediate thought in the emergency department is rightly subarachnoid hemorrhage, but RCVS must be high on our differential diagnosis. The vasoconstriction isn't just painful, it can lead to both ischemic and hemorrhagic strokes. This fact alone transforms what might seem like just a headache into a true neurological emergency with the potential for devastating consequences. This leads directly to its substantial impact on both patient morbidity and healthcare resources. Even after the acute phase resolves, many individuals are left with persistent headaches, mood disturbances, or cognitive complaints that affect their quality of life and ability to return to work. For our healthcare systems, the burden is considerable. These patients often require extensive and repeated investigations, CTs, MRIs, and cerebral angiography, alongside prolonged hospital stays and specialist neurology follow-up. The diagnostic uncertainty consumes a disproportionate amount of our clinical time, energy, and resources. This complex clinical picture raises a critical question. With its varied presentations and dangerous mimics, how do we confidently distinguish RCVS from other conditions? To answer that effectively, we first need a robust and clear set of definitions. Given the serious, and sometimes devastating, outcomes we've just discussed, it's crucial we have a precise and shared understanding of what this syndrome actually is. A clear definition is the foundation for accurate diagnosis and effective management. At its core, RCVS is a syndrome of recurrent vasospasm affecting the cerebral arteries. Effectively, the muscular walls of these blood vessels in the brain suddenly and repeatedly clamp down, or spasm. This isn't a single event. The recurrent nature, often over several days, is a true hallmark of the condition and is what drives much of the clinical picture. The most important word on this slide, however, is reversible. While the arterial narrowing can look alarming on imaging, it isn't permanent. A helpful way to think about this is like a severe muscle cramp, rather than a permanent blockage. The artery spasms and narrows, but then, over a period of days to weeks, it spontaneously relaxes and returns to its normal caliber. This reversibility is the key feature that distinguishes RCVS from other serious conditions like primary angiitis of the central nervous system. To formalize the diagnosis, we rely on the ICHD-3 criteria. The first pillar is the thunderclap headache. This is not simply a bad headache, it's a sudden, explosive pain reaching maximum intensity in under a minute. Patients often describe it unequivocally as the worst headache of my life. The second pillar is objective evidence of segmental vasoconstriction from an angiogram. In practice, this often creates a characteristic string of beads appearance, with sections of arterial narrowing alternating with areas of normal or even dilated caliber. This diagnostic framework is essential for clinical practice. But it immediately raises a fundamental question: what triggers this dramatic and painful vasospasm in the first place? Why do these arteries suddenly begin to misbehave in this specific, reversible way? Now that we've clarified what RCVS is, the immediate clinical question becomes, who is at risk, and what can precipitate such a dramatic event? The etiology is surprisingly diverse, yet certain patterns are very clear in clinical practice. A classic and critical trigger is the postpartum period. The profound hormonal and hemodynamic shifts following childbirth create a window of vulnerability for arterial dysregulation. We also see a strong link to vasoactive drugs. This isn't limited to illicit substances. Common culprits include prescribed medications like SSRIs, triptans for migraine, and even over-the-counter nasal decongestants. This is why a meticulous medication history is absolutely essential when a patient presents with a thunderclap headache. Demographically, the picture is quite distinct. RCVS has a clear predilection for the female sex, and it typically affects a younger cohort than we associate with most cerebrovascular events, usually patients between 30 and 50 years of age. This profile can be a diagnostic red flag, prompting us to consider RCVS in a patient who doesn't fit the typical demographic for a stroke. So what's the common thread tying these disparate triggers together? The evidence points towards a sudden catecholamine surge or a state of underlying autonomic instability. You can think of this as the body's fight or flight system going into overdrive, but in a dysfunctional way that specifically targets the cerebral arteries. This surge could be triggered by exertion, emotion, or the chemical properties of a drug, but the end result is the same: a powerful, uncontrolled spasm of the blood vessels in the brain. This concept of a powerful vasospastic response is the key. But what exactly is happening at the level of the arterial wall to cause this severe, yet reversible, constriction? What is the mechanism behind the thunderclap headache and the fluctuating neurological deficits? We've just reviewed the wide array of potential triggers for RCVS, from vasoactive medications to the physiological shifts of the postpartum period. The question, then, is what is the final common pathway? How do these diverse factors all lead to the same dramatic arterial constriction? The answer lies in a transient, but profound, dysregulation of cerebral vascular tone. A helpful way to think about this is to picture the brain's arteries as sophisticated, self-regulating conduits. In RCVS, the system that governs their diameter, telling them when to constrict and when to relax, temporarily fails. This isn't a permanent structural problem. It's a functional one, but with potentially serious consequences. On a molecular level, what we see is a critical imbalance between two key chemical messengers. On one side, we have endothelin-1, an extremely potent vasoconstrictor. On the other, we have nitric oxide, our body's primary vasodilator. In a healthy state, these two forces are in equilibrium, maintaining normal blood flow. In RCVS, the balance tips dramatically. Endothelin activity surges, or the nitric oxide system fails to respond, leading to uncontrolled arterial spasm. The ultimate driver behind this biochemical chaos appears to be sympathetic overactivity. This is the body's fight or flight response going into overdrive. Remember those triggers we discussed? Many of them, like certain drugs, intense physical exertion, or even strong emotion, are known to provoke a massive sympathetic discharge. In practice, we see this surge as the primary event that disrupts the endothelin and nitric oxide balance, causing the vascular dysfunction at the heart of this syndrome. So, we have this physiological storm, a cascade of sympathetic overactivity leading to arterial spasm. What does this actually look like from the outside? How does this internal chaos manifest for the patient sitting in our emergency department? That dysregulation of cerebral vascular tone we've just examined doesn't remain a silent, microscopic event. In clinical practice, its consequences manifest in a sudden and often terrifying way for the patient. The most common presentation, and a critical red flag, is the thunderclap headache. This isn't just a severe headache, it's a headache that reaches its maximum, excruciating intensity within 60 seconds. Imagine a switch being flipped from 0 to the worst pain imaginable. That's the experience for the vast majority of patients with RCVS. This symptom alone demands immediate and serious investigation. But the effects aren't limited to pain. When those arteries constrict, the part of the brain they supply struggles for oxygen, leading to focal neurological deficits. What we commonly see are symptoms like temporary visual disturbances, a loss of sensation, or weakness down one side of the body. In more severe cases, this cortical irritation can even trigger a seizure. These deficits are a direct, real-time consequence of the dynamic vasoconstriction happening inside the cranium, and they can be just as alarming as the headache itself. If that constriction is profound enough, or persists for too long, the brain tissue can suffer irreversible injury. This is where RCVS can lead to ischemic stroke. The symptoms will mirror those of a typical stroke because the underlying mechanism, a lack of blood flow, is the same. If the blood flow is restored before permanent damage occurs, the patient might experience a transient ischemic attack, or TIA. This progression highlights the time-sensitive nature of the condition and its potential for causing lasting harm. So, when a patient arrives in the emergency department with this constellation of severe headache and fluctuating neurological signs, the picture is often confusing and alarming. The crucial question then becomes, how do we confidently distinguish RCVS from its dangerous mimics? So, a patient presents with that characteristic thunderclap headache we just discussed. The immediate challenge is to confirm our suspicion of reversible cerebral vasoconstriction syndrome whilst ruling out more sinister causes. This is where our diagnostic imaging and investigations become absolutely crucial to navigate this clinical crossroads. Our primary tool is often magnetic resonance angiography, or MRA. On these scans, we're looking for a very specific pattern, segmental vasoconstriction. A helpful way to think about this is the classic string of beads appearance, where arteries show alternating segments of narrowing and normal caliber. This isn't a continuous tapering, it's a distinctive, beaded pattern that is highly suggestive. This is the hallmark visual sign of RCVS, but the key word is reversible. A follow-up scan weeks later should show resolution. Similarly, CT angiography can reveal this same multifocal narrowing of the intracranial arteries. In many centers, a CTA of the head and neck is the first-line investigation because it's fast and readily available, particularly in the emergency department setting. It gives us a rapid initial assessment. While it provides a clear snapshot of the arterial narrowing at that moment, it's the combination of this finding with the classic clinical picture that builds our diagnostic confidence. It confirms the V in RCVS, the vasoconstriction, and helps to exclude an aneurysm. Finally, we perform a lumbar puncture. Now, you might expect us to be looking for a positive finding, but for uncomplicated RCVS, the opposite is true. The cerebrospinal fluid is typically normal, or shows only a mild, non-specific increase in protein or white cells. The real purpose of the LP is one of exclusion. It helps us confidently rule out critical mimics like aneurysmal subarachnoid hemorrhage or central nervous system vasculitis, which would present with significant CSF abnormalities. A normal result is therefore powerfully reassuring. So, we have these powerful diagnostic tools, but the picture they provide is a dynamic one. The vasoconstriction waxes and wanes. This raises a critical clinical question. What does the evidence actually tell us about the best timing for these investigations and the long-term prognosis for our patients? Once we've used our diagnostic tools to identify that characteristic string of beads pattern on angiography, the immediate question becomes, what does this actually mean for the patient? What does the evidence tell us about the natural history of this condition and the risks they face? And on that front, the news is largely positive. The data consistently shows that in the vast majority of cases, around 85%, the arterial narrowing we observe on imaging completely reverses over weeks to months. This reversibility is the defining feature of the syndrome. It's the crucial piece of information that distinguishes RCVS from other, more permanent forms of vasculitis, and it's a vital point for patient reassurance. However, certain populations demand a heightened vigilance. The evidence clearly links the postpartum period with a higher incidence of RCVS. So, when a new mother presents to the emergency department with that sudden, explosive thunderclap headache, RCVS must be extremely high on our differential diagnosis. It's a classic association, often triggered by physiological changes and sometimes vasoactive medications used during or after delivery. Missing this connection can have significant consequences. But here's the critical counterpoint to that reversibility. While the vessels may heal, the damage done can be permanent. Large-scale analyses confirm that the most feared complication is stroke, both ischemic and, less commonly, hemorrhagic. This occurs in roughly a quarter of all individuals diagnosed with RCVS, a direct consequence of severe vasoconstriction starving brain tissue of oxygen. The headache is the alarm bell, but the potential for a life-altering stroke is the fire we are racing to extinguish. That sobering statistic, the risk that 1 in 4 patients may suffer a permanent neurological deficit, perfectly frames our clinical imperative. It shifts the focus from simple diagnosis to active intervention. So, how do we intervene to mitigate this risk and promote complete vascular recovery? That evidence gives us a clear mandate for how to act when a patient presents in crisis. Our approach to treatment is fundamentally about navigating a very delicate physiological balance, where doing less is often much more effective and safer than doing too much. In the acute phase, the primary principle is caution. The cerebral arteries are already in a state of hyperreactivity, so introducing further vasoactive agents is strictly contraindicated. This includes the very substances that may have triggered the syndrome, like triptans or certain nasal decongestants. Similarly, while hypertension is common, aggressively lowering blood pressure is dangerous. A precipitous drop risks reducing perfusion to already compromised areas of the brain, potentially converting reversible ischemia into a permanent infarction. Gentle control is the objective here. This is where calcium channel blockers become the cornerstone of our pharmacological strategy, with nimodipine being the agent of choice. Its mechanism is quite elegant. It has a preferential effect on the cerebral arteries, helping to counteract the intense vasospasm. A helpful way to think about this is not as a cure, but as a modulator. It reduces the severity of the constriction and the intensity of those thunderclap headaches, buying the brain valuable time to recover. In practice, we often see a dramatic improvement in symptoms once nimodipine is started. Of course, medication is only one part of the picture. We cannot forget the fundamentals of supportive care. This isn't passive management, it's an active process of creating the optimal physiological environment for recovery. Maintaining good hydration, providing effective but non-vasoactive analgesia, and preventing seizures are all vital. Each measure helps to minimize stress on the brain, allowing the natural resolution process to proceed smoothly. So, we've initiated these therapies to stabilize the patient. But this is a dynamic condition. How do we track their progress and confirm that the vasoconstriction is truly reversing as we expect? What does that crucial next phase of care actually involve? Once we've initiated treatment and the acute phase begins to settle, our focus pivots to ensuring a complete and safe recovery. This isn't a condition where we simply discharge the patient and hope for the best. diligent monitoring is absolutely paramount to confirm resolution and prevent complications. The cornerstone of this follow-up is demonstrating that the vasoconstriction has, in fact, reversed. In practice, this means scheduling serial imaging, often with transcranial Doppler, CT, or MR angiography. We're looking for tangible proof that the arteries are returning to their normal caliber, usually over a period of 4 to 8 weeks. This objective evidence is what provides confidence, for both us and the patient, that the underlying pathological process has resolved. It's the visual confirmation that our diagnosis was correct and the condition is living up to its reversible name. Of course, while imaging provides the objective data, the patient's subjective experience is just as critical. We must counsel them to remain vigilant for any recurrence of that characteristic thunderclap headache, or any new neurological deficits. Remember, whilst RCVS is typically a monophasic illness, relapses can occur, especially if an initial trigger is reintroduced. A sudden, severe headache weeks after the initial event is never just a headache. It is a red flag that demands immediate reassessment. For the majority, symptoms and vasoconstriction resolve within 3 months. But what about the outliers? In cases with persistent headaches, prolonged vasoconstriction on imaging, or where the diagnosis remains in any doubt, referral to a specialist vascular neurology service is essential. These teams possess the deep expertise required to investigate complex cerebrovascular mimics and manage those atypical cases that don't follow the textbook. This referral is our crucial safety net. This follow-up protocol seems quite clear on paper. But what happens when the imaging doesn't normalize as expected? Or when the patient's story has confounding factors? The reality of diagnosing and managing RCVS is not always straightforward, and it's filled with potential pitfalls and genuine clinical controversies. While vigilant monitoring helps us track the evolution of RCVS, its effectiveness hinges on getting the diagnosis right from the outset. Here's where the clinical journey can become incredibly challenging, as the condition is surrounded by pitfalls and genuine controversies that we must navigate in our practice. The most significant pitfall is misdiagnosis. Because of its presentation with thunderclap headache and multifocal vasoconstriction, RCVS is frequently confused with aneurysmal subarachnoid hemorrhage or primary central nervous system vasculitis. The danger here is profound. Treating a patient for vasculitis with high-dose corticosteroids, for example, may not only be ineffective for RCVS but could potentially worsen the vasoconstriction. In practice, the key is the temporal profile. The reversibility of RCVS over weeks to months is its defining feature, unlike the progressive nature of untreated vasculitis. Then we face therapeutic uncertainty. A pressing question is whether to use prophylactic antiplatelet agents, like aspirin, to prevent ischemic stroke. On one hand, it seems a logical maneuver if a patient already has small infarcts. On the other hand, we lack robust randomized trial data to support this, and we must weigh this against the risk of promoting hemorrhage, which also occurs in a subset of RCVS patients. The decision remains highly individualized, a true exercise in clinical judgment at the bedside. Finally, the very etiology of RCVS is a subject of emerging research. We're beginning to explore the possibility of a genetic predisposition and the role of underlying autonomic nervous system dysfunction. This could explain why certain individuals develop RCVS in response to common triggers, while most do not. If a genetic link is confirmed, it could pave the way for identifying at-risk populations and developing more targeted preventive strategies in the future. These points reveal a condition that is far from a solved puzzle, with diagnostic mimics and therapeutic dilemmas. So, in the face of this complexity, what are the core, evidence-based principles we must anchor our practice to for every patient? Navigating the controversies surrounding RCVS can feel complex, but when we strip it all back, what are the absolute, non-negotiable principles we must carry into our clinical practice? A few key pillars stand out, providing a firm foundation for diagnosis and management. First, at its very heart, RCVS is defined by two features: a sudden, severe, thunderclap, headache and multifocal cerebral vasoconstriction that resolves on its own. The headache is the alarm bell, but the reversibility of the arterial narrowing is the truly pathognomonic sign, confirming the diagnosis retrospectively. Second, always maintain a high index of suspicion in specific patient populations. The postpartum period is a classic setting for RCVS, as are patients using vasoactive substances, from prescribed antidepressants like SSRIs to over-the-counter decongestants. A thorough medication and substance history isn't just helpful, it's often the key that unlocks the diagnosis. Third, diagnosis hinges on advanced imaging. While a non-contrast CT may initially exclude a subarachnoid hemorrhage, it's the vascular imaging, CT or MR angiography, that reveals the characteristic string of beads pattern of vasoconstriction. This imaging confirms our suspicion and, just as importantly, helps rule out other mimics of thunderclap headache like primary angiitis of the CNS. Fourth, our primary therapeutic intervention is the use of calcium channel blockers, such as nimodipine. The goal here isn't to cure the condition instantly, but to alleviate the severe headaches and, crucially, to reduce the risk of ischemic or hemorrhagic complications while the underlying vasoconstriction resolves. They act as a vital bridge to recovery. And finally, our role doesn't end with the initial treatment. Follow-up is essential. We need to repeat vascular imaging in the subsequent weeks to months to confirm that the vasoconstriction has indeed resolved, fulfilling the reversible part of the syndrome's name. This confirmation gives us, and our patients, confidence that we've managed RCVS and not missed a more permanent vasculopathy. These principles represent our current best understanding, synthesized from a growing body of case series, observational studies, and clinical experience. The foundation of this knowledge is, of course, the rigorous work of researchers and clinicians around the world. The evidence base supporting today's discussion is listed here for your reference. These studies and guidelines underpin the key points we've covered throughout this presentation. That brings us to the close of our discussion on reversible cerebral vasoconstriction syndrome, a clinical and pathophysiological perspective. We've covered a lot of ground today, from the foundational concepts through to practical implications. I hope the evidence and insights we've explored give you a solid framework to work with. I'd welcome any questions or thoughts you'd like to share. You can also access the slides using the QR code on screen. Thank you for your time and engagement.